Hello, everyone, and welcome to today's session on the updated VHL Surveillance Guidelines and what they mean for you. Today, I'm excited to welcome Dr. Anthony Daniels. Dr. Daniels is an assistant professor of ophthalmology and visual sciences and radiation oncology, as well as the director of ocular oncology at the Vanderbilt Eye Institute at Vanderbilt University Medical Center. He graduated summa cum laude from Princeton University and subsequently received a master's degree in public health policy from the London School of Economics. After graduating from the University of Pennsylvania School of Medicine, he completed an internship at the Memorial Sloan Kettering Cancer Center and both his ophthalmology residency as well as a retina surgery fellowship at Harvard Medical School, Massachusetts Eye and Ear Infirmary. He subsequently pursued additional tumor training at Memorial Sloan Kettering Cancer Center and the Mayo Clinic. Dr. Daniels has been nationally recognized for his research, which focuses on minimizing complications associated with eye cancer treatment and in understanding and preventing the spread of cancer cells from the eye to the rest of the body. Dr. Daniels was awarded the Ronald G. Michaels Award, given to the top retina fellows in the country, as well as the Ronald Marghiero Research Award from the Retina Society. He is a diplomat of the American Board of Ophthalmology. He has authored an ophthalmology textbook, as well as more than 20 peer-reviewed papers and book chapters, and has received more than a dozen research awards. Dr. Daniels is the retina specialist for the VHL Comprehensive Clinical Care Center team at Vanderbilt, as well as the chair of the VHL Surveillance Guidelines Task Force. Dr. Daniels, thank you for joining us today.
Thank you for having me. So as everybody knows, right, VHL can affect many different organ systems, and it causes morbidity and mortality for patients in many different ways. And like basically many types of things in medicine in general, and in cancer in particular, the sooner you find the causative problem, the better your options are for treatment and the better your ability to minimize morbidity and mortality. And so the question has always been how to best do this. And with VHL and with many other tumor predisposition symptoms, the answer is active surveillance, ideally to catch tumors before they become so large that they become symptomatic, to catch them when they're still in the pre-symptomatic phase, when the options for treatment are better, treatment's easier, complications of treatment are fewer, and there's less morbidity and mortality. So this originally evolved out of the VHLA Biennial Symposium in Houston in 2018, and there's a panel discussion on how best to implement active surveillance and where the guidelines were at that point and where they needed to be. And from this, we identified several problems with the myriad current guidelines that were out there at the time. For the most part, the guidelines that were in existence at the time were based on expert opinion, and it was generally a panel of individuals with one expert in each area. And so it ultimately ended up being the expert opinion of that one individual. And there were also biases between different countries, so that the guidelines for any given country were geared towards what how the healthcare system was set up in that country. So, for example, what came out as we were having this, as this consortium evolved and as the different subcommittees that I'll talk about were having their discussions is, for example, a renal ultrasound in one country might not mean the same thing as a renal ultrasound in another country. In some places in Europe, if you order a renal ultrasound, you also get the abdominal organs included. Whereas in North America, if you order a renal ultrasound, you get a renal ultrasound. If you order an abdominal ultrasound, you get an abdominal ultrasound. And you don't necessarily have the overlap. So in an effort to make this sort of as global as possible, we wanted to make sure that we were specific and that we knew what the wording that we used meant the same thing to everybody. The other problem, a really large problem, is that for many of the guidelines that were out there, as we said, they're related to expert opinion, and they weren't necessarily definitively tied to evidence. You know, so people did this because this is what people did, and this is what people always did. And what do you mean we should talk about something different? But there may not actually be the evidence that we assume there is to underlie certain decision making. And we also wanted to ensure that the guidelines were very transparent for everything that we recommended, that it was very clear why we recommended it, what was the level of evidence, how strong was that evidence, and the degree to which we were relying on specific evidence versus sort of just extrapolating. And the reason that it's important over time to reevaluate is that as we learn more about disease processes and about natural history of disease and new treatments develop, best practices for surveillance also have to evolve. So these guidelines, which I'll share very shortly, were really the effort of the International VHL Surveillance Guidelines Consortium. And the table of guidelines you're going to see in a minute, and that's actually already available through the VHLA website, is really just the tip of the iceberg. So, what do I mean by that? The main guidelines, which are what we're going to talk about today, are really intended for anybody and everybody to use, right? They're general guidelines. So they're intended for everybody from the VHL specialist, who's a point person for surveillance imaging for their VHL specialty clinic, to a primary care physician in a small town who, due to geographic constraints, can't send the patient to a VHL specialty clinic and maybe trying to decide how best to manage the only VHL patient they've ever seen in their entire career, to patients who want to advocate for themselves and know what should be being done for them as best practice surveillance. But in addition to this general table, which is really the focus of the phone call today, there's also organ-specific and tumor-specific subspecialty guidelines, and these are written as highly technical and detailed guidelines intended for subspecialists in the field. So if the main guidelines are intended to try to screen for tumors and to identify ones that require referral for intervention, then the organ-specific guidelines are intended for those subspecialists who get those referrals, how to monitor lesions that are growing, specific additional testing. It's written in highly technical jargon because it's intended for people who are familiar with that, and it helps to guide management decision-making, when to treat, how to treat, et cetera. And both the overall guidelines as well as the organ-specific guidelines are intended to be published in their respective medical journals, where they'll get to the most pertinent target audience. So great. So this is an overview of the entire consortium and how it was sort of structured. So these are all the people who are involved in the various aspects of writing. So each committee was composed of specialists in the field. So for example, the kidney committee that was tasked with surveillance for renal cell carcinomas, they're medical oncologists who specialize in VHL of kidney cancers, such as Kim Rathmel and Uthin Iliopoulos. And then there are also urologists who are involved in surgical management, such as Philip Spies and Eric Yonash. And the idea was to bring them all together to look at that specific organ, to come up with specific guidelines for specialists, but also to then contribute to the main writing committee, which was composed of the subcommittee chairs of the various organ-specific subcommittees. And in addition, you can see that there was a radiology subcommittee that advised all the committees, as well as the overall main writing committee on aspects related to radiology, timing of giving contrast agents and things like that, specific sequences, as well as representatives from pediatrics, from anesthesia and pediatric anesthesia, experts on guideline writing, et cetera. And so each subcommittee basically first identified specific questions that they wanted to ask and answer. So for example, what age to start? Can you stop imaging a person who's never developed a tumor? And if so, at what age? How frequent does the imaging need to be? What's the best modality to use for a given organ? So for example, MRI or ultrasound. And then after identifying these specific questions, they went to the literature to see what was actually known about this. It's one thing to say, well, we think we should start around age 15, but is there actually evidence that 15 is the right age, or can tumors form earlier, later, et cetera? And then as they developed the guidelines, they used a standard toolkit for guideline evaluation that's been around for decades, and sort of standardized around this grading of the evidence levels, as well as the strength of the recommendation using the NCCN strength of evidence guidelines. And then all the subcommittee chairs got together over a series of phone calls, emails, conference calls, et cetera, to try to basically hash out and coordinate this so that you don't have a situation where all different testing is on their own schedule. We try to make it such that from a patient perspective, it would be much simpler to understand when different things are starting. Not that something starts at age 10, something at age 12, something at age 14, something at a different thing each time. And this is sort of how we got to where we are with the overall guidelines. So looking here, the guidelines are intended, the table is intended to be something that you can kind of have on hand and be usable. And this particular version of the guidelines, both addresses what happens for any given tumor type, but also what patients can expect to happen at a given age. So looking up here at the top, you can see that we talk about what happens before age 5, and then what happens between, beginning at age 5, and then beginning at age 11, and then 15, and then there's only one little change at age 30, and then 65. So I like to think of this as the 5, 11, 15, 30 rule. Okay. So without, getting terribly detailed, for each one, we talk about what happens. And generally, at different ages, different things get introduced. So beyond the age of 15, basically everything is being involved at that point, but they don't all start at the same time. And the other critical thing to see is that the entire bottom half of the page is footnotes. So while you can refer to the top, anybody using this really does need to pay attention to the specific details at the bottom, which tell you how to interpret it, situations in which this doesn't apply. So for example, if you look at MRI brain and spine with contrast halfway down the table, or if you look at MRI of the abdomen, close to the bottom of the table, while they do both say that scans should be done every 2 years, Q2 years, that assumes that either there hasn't been anything found and you're doing screening imaging, or that you have, long-term evidence of stability of the lesions, right? Obviously, if you find something new or if you have something that's growing, you're not going to wait 2 years. And so the footnotes talk to you about, how do you implement this in practice? And there are a lot of differences between this set of guidelines, or practical differences between this set of guidelines and former guidelines as well. So, looking here, if you look at the MRI, if you look at the abdomen, right, so this is to look for renal cell carcinomas, pheochromocytomas, pancreatic neuroendocrine tumors or cysts, et cetera, and the imaging's every 2 years. A lot of the previous versions of the guidelines talked about using ultrasound or alternating MRI with ultrasound, or using ultrasound in younger people and then evolving to MRI when you get to age 15 and things like that. And we've basically decided that if we all felt, and we did all feel, that MRI was the best option, then really that should be what's being performed. And if we felt that adding the ultrasound in the intervening years didn't really add much, then there's no reason to perform that, and just stick with the best possible option that there was, which we all felt was MRI. And here, where you're looking for multiple organs, there had to be a bit of discussion about what's best for all the different organ systems. Also, with a cancer predisposition syndrome, you ideally want to minimize the amount of radiation you're exposing patients to. And so MRI was favored over CT for that reason as well. Similarly for MRI brain and spine, MRI was obviously the best modality. In contrast, for when you're looking for pheochromocytomas, for example, metanephrines was really felt to be the best way to screen. And while you are getting MRI of the abdomen and you do see the adrenals, it was more just being tagged on to the search for renal cell carcinomas. And so the idea was that if metanephrines was best for the endocrine manifestations and for finding pheochromocytomas, then it was, when it came to imaging the adrenals, it was less important to have the ideal imaging modality if it was going to interfere with the ability to image things for which imaging was really important, like renal cell carcinoma. You can see as you look at the previous guidelines, and I alluded to this, that ultrasound featured a lot more in previous guidelines. And if you look at the VHL Alliance guidelines from 2015, the idea was that you would start ultrasound earlier in younger patients, maybe who couldn't tolerate an MRI without anesthesia. And as we actually went to the evidence and the literature to look at this, it really seems that, for example, renal cell carcinomas before the age of 15 really are very, very uncommon. And so the idea of doing the ultrasounds before then probably wasn't adding very much. And so we just picked up with beginning imaging the abdomen at age 15. In contrast, we felt that imaging the central nervous system to look for hemangioblastomas did need to begin earlier. So instead of beginning it beyond age 16, as it had been in previous versions, we moved it back to age 11, based on when it was known that these begin to form. So while I could go through every box and square in these tables, I think I'd rather sort of maybe answer questions about how to use them, how to interpret them, what they mean, what's changed, rather than sort of reading the whole tables out, because they're intended to be looked at.
That sounds great, Dr. Daniels. Thank you. So we have a number of questions here.
Okay.
The first question is, what are the changes in these updated guidelines from the previous ones, and what is the rationale for the updates?
Yeah, so I began to allude to this. The rationale for the changes was that we actually looked at the evidence that supported them. So even if things were being done, because it seemed to make good sense, we wanted to actually ensure that what we were doing was actually based on what we knew to actually help patients. And then we tried to ensure that the guidelines would be international in scope and could be applied to people in any and every country. And so the approach that we took to coming up with the guidelines was different. And then that in turn led to a difference in the actual recommendations. So there's much more of a standardization on using MRI instead of leaving it to alternating between different between different modalities. As I mentioned, some things begin later, some things begin earlier. And we tried to, in general, standardize on what we thought was best practice rather than leaving it as several options.
The next question is, do the updated surveillance guidelines address the use of the 35-minute MRI protocol, or do they recommend using traditional MRI methods?
Yeah, so they don't really specify. They don't address the 35-minute protocol because it's not something that's necessarily at this point in time widely available everywhere. And if you were to put this in people's hands across the world, there'd be a lot of people who wouldn't know about it or wouldn't have necessarily access to it or get their imaging done at a center that offers it. So it's intended that patients would get standard MRIs of these different organ systems. And particularly if you look at the footnotes, it talks about how best to combine them into a single MRI. And if you're going to combine them, the sequences, and also how to time the contrast administration so that you're getting what you need for each one. So you're not giving multiple, rounds of gadolinium. But you certainly could employ a 35-minute protocol and still, it would still work with this table, but it was written to assume that people would have access to normal MRI and not necessarily the 35-minute MRI protocol, which, by the way, is wonderful.
So for certain types of surveillance, the updated guidelines call for scans every 2 years. Does this include people who already have manifestations? If not, what should the scan intervals be for those with existing known manifestations?
Yeah, so that's a great point. And I think it's really important to reemphasize that, for example, 2 years is for somebody who is being, what's called primary surveillance, meaning looking for a tumor that's not already there, right, to see when it develops. And then for patients who have tumors in that particular organ, there are footnotes on the table that say, for example, if renal cell carcinoma is less than 3 centimeters are identified, then you should scan every 3 to 6 months until you've determined that the rate of growth is standard or that they're not growing. And then you can stretch it back out and sort of walks you through that. Same thing for CNS hemangioblastomas. If there's nothing, 2 years, or if there's long-term stability, 2 years. But if there is, if you find something or it is growing or of course becoming symptomatic, then you would either refer to neurosurgery or it talks about how to increase the frequency. And the data, for example, on CNS hemangioblastomas, this is all data driven, right? So there's a lot of really good work out of some of the large groups VHL groups in Europe that talks about what is the standard rate of growth of these tumors. And, if you go 2 years versus imaging at 1 year, are you actually going to miss any tumors before a time when they need to be found or become symptomatic or anything like that? And so that 2 years was based on actual hard data about how fast these tumors grow. And it was felt that at 2 years, you would be unlikely to miss something from the previous scan, miss it before it really became a problem. But to answer the question, no, that assumes that there's nothing there or there's long-term stability. The footnotes go into how to increase frequency if there's something actually that you're following or that's growing.
How will the new guidelines be distributed and announced to doctors?
So in 2 ways. So they're already available on the VHLA website, which everybody knows how to get to and should look at. And then it's also in the VHLA's patient handbook, and it's being sent to all of the comprehensive clinical care centers and clinical care centers around the world. And then in addition, the actual actual scientific paper that goes through the evidence supporting these and presents the guidelines is being submitted for publication, and the individual organ-specific, subspecialty directed guidelines are also being published, and they're all being published not just as a set of guidelines, but going into the detail of what, and being very transparent about the strength of the recommendations and the evidence underlying them. So the idea is that my colleagues in ocular oncology and retina specialty and things like that, probably are reading the high impact ophthalmology journals a lot more than they're reading the general cancer journals. And so it's important that that gets into a correct ophthalmology journal, whereas the overall guidelines would go into an oncology journal.
That's fantastic. I think it's going to make a big difference in patient care. Will doctors be forced to abide by these surveillance guidelines, and what happens if they don't?
That's a really great question. So obviously, no one's forced to do anything. These are just like a lot of things, guidelines of what we feel is best practice based on the evidence. And this was really something that we tried to take into account in writing the guidelines. That we didn't want to step in between doctor-patient relationships. And, there are lots of things that go into guidelines that maybe are patient-specific, particularly, and this also comes out in some of the footnotes, if a family was known to have a particular manifestation at an earlier age, or if there's a question of what's called, anticipation, what happens earlier in later generations, then, you may want to start earlier, or you may, obviously, if symptoms arise, things like that. The other thing we tried to be very careful in writing the guidelines was not to create a situation where doctors' or patients' hands were tied. So we didn't want to write it in such a way that said every 2 years, because if there was a good reason to do it sooner, or in a given patient to test more frequently, or to order a different test, we didn't want to have a situation where, like, for example, in the US, where insurance companies have a lot of sway over this, to have a situation where they could point to the guidelines and say, no, we're not going to cover this, or you're not allowed to do this until the 2-year time point. So we tried to include an understanding that these are guidelines, and we really do feel that these are best practice, but there may be certain patients or certain circumstances in whom more frequent testing might be required, or earlier testing might be required, or, as the footnotes get into, if you can't get an MRI because you have a cochlear implant, or because you have metal in your body, what would be the next best option? And so it sort of runs through all those different options and helps physicians and patients work through these decisions.
So what role do patients and caregivers play in making sure that they're getting the appropriate surveillance?
Look, I think that the best patient is a well-informed patient, and it allows patients to advocate for themselves. The hope is that all physicians are doing things according to the guidelines and according to best practice, but it's also important that patients, are able to step in and say, hey, I thought I should be, starting to get an MRI at this age. How come we haven't talked about that yet? The other thing is that I think it really helps patients to understand what to expect long term, right? If you have a young child who is diagnosed with VHL, to understand that, well, at this age, they may only be requiring a physical examination, or an annual or every 6-month eye examination, to understand that, while beginning at age 5, there's going to be more added, and beginning at age 11, there's going to be more added, and beginning at age 15, there's going to be more added. So it helps to demystify the process for patients and families, and helps them to understand, so they don't feel like, oh, how come every time I go back, they're suddenly adding on something? Did they forget to do it last time? Did they only figure out now that they're supposed to be ordering an MRI of the abdomen? Well, no, it's just that the child turned 15 and now it's the appropriate time. So it helps to sort of plan long term, and particularly for families that maybe have multiple a parent and multiple children with VHL. It helps to understand why different children are getting different testing at different ages. Also, for planning purposes, if you're going to travel long distances, it's good to know who's going to need what next time you have to come back in a year, a couple of years from now.
Now, obviously, VHL requires a bunch of specialists from a wide range of specialties, but which doctor, whether it's the PCP or a specific specialist, should be the one responsible for ordering all the surveillance and then tracking the results?
I think that that's also very context specific. There's a lot of good evidence that for rare diseases, such as, for example, VHL, there physicians who have a lot of experience with the disease may be in a better position to manage those patients. And this is a part of the context for the creation of the comprehensive clinical care centers and clinical care centers, right? That if you're seeing something day in, day out, you probably have a good handle on how to handle the data coming in versus if you're seeing it once in a lifetime. Now, look, for a lot of people, that's not necessarily possible, right? If you happen to live many, many hours away from the nearest clinical care center, nearest VHL specialist, that may not be feasible. Now, if you actually develop manifestations, it may be worth the drive. But if you have none, it really depends on what access you have to specialty care. I think that regardless, though, it's really important that patients have a medical home. And there's a lot of evidence from lots of different multi-system diseases that, there's a lot of fragmentation of care. And this is certainly true with VHL as well, right? If you have, you may see, and we've had patients who've been referred to us who are just like this, you may be seeing 5 different subspecialists, but each is completely focused on their own specific organ system. And each is assuming, they see a list of 5 other subspecialists and they assume that everything's covered. But, lo and behold, actually, there was one aspect of surveillance that wasn't covered. And patients had very advanced tumors, as it turns out, in that particular organ because it was the one that was left out, So the idea of having a particular medical home or a particular physician who is the point person for ensuring that this all happens is very, very important. And that's why all the clinical care centers are set up to have a point person as well to help facilitate for patients. So in an ideal world, yes, patients would be managed at specialty, multidisciplinary specialty clinics. But I understand it's not always possible. I think it's just important to have somebody be the person who takes responsibility for ensuring that the entire patient is well cared for, not just the specific organs that have tumors in them. I had a patient who knew they had VHL for 20 years. They were in their mid-20s because they'd had a pheochromocytoma, and they were never told that that this could affect their eyes and that they needed to get eye examinations. So they never had eye examinations until they presented with a massive retinal hemangioblastoma in their mid-20s.
So at what point should patients transfer, whether it's their general care, VHL-related care, or care over a specific issue? When should it be transferred from their PCP or general practitioner to a VHL specialist?
Yeah, so I think it depends on the comfort of the person who's primarily managing them, right? So if your primary person is a medical oncologist at a VHL, clinical care center, so if the person who's managing all of your organ manifestations is, so for example, at my institution's Kim Rathmel, right? If she's a person who's managing, then I feel very comfortable that she has a good handle on what a normal rate of growth for a particular tumor is, right? Again, if it's with somebody who's just trying to get through what needs to be done because they don't have a lot of expertise with this, but they're trying to help patients in their location, then they probably would have a lower bar to refer the patient. The tables themselves do get into the details of when to refer somewhat. And so that the footnotes of the table get into that. And so I think that that's helpful guidance. But, I think that for people who aren't managing VHL patients day in, day out, probably it's good to have a relatively low bar to at least refer for an opinion on something if there is a tumor, if there's anything that's changing or symptoms, of course. And even for VHL experts, who are managing patients, they also need to know when to refer to a subspecialist. Be that person neurosurgeon, urologist, et cetera.
So I think we have time for just one or two more questions. How much do the guidelines change for those who are diagnosed later in life?
Yeah, I think that, screening, it depends on how they were diagnosed, right? So if they were diagnosed with a particular manifestation, then of course, the screening guidelines don't apply to that particular organ system. They will get surveillance based on what the needs of that particular organ system are. But for the diagnosis and the rest of the patient, you can really sort of jump into where you are. So if you are 25, then you say, okay, what should a 25-year-old be getting at this point? Of course, there'll be a lot of catch-up to be done because they presumably won't have had all the other imaging previously. But the one exception is, things that get done a single time. So if you're 25 and you're diagnosed because of a pheochromocytoma, right? At age 25, you wouldn't necessarily be getting imaging, specifically imaging for, the one-time imaging for ELST, for endolymphatic sac tumors of the internal auditory canal. And so that generally happens at an earlier age, in the early to mid-teens, or the mid-teens. And so if you never had that, of course, you would want to get that as a baseline, in addition to, for example, the audiograms for endolymphatic sac tumors in the inner ear, which would continue, periodically, even at age 25. Of course, for people who are diagnosed and then they're close to age 65, we sort of settled on age 65 as an age in which certain things could end in terms of the need for routine surveillance. Again, that's in patients who never had manifestations in that organ system, right? So when we say you don't need routine CNS MRIs beyond age 65, that's for somebody who never in their whole life had a CNS hemangioblastoma. If you're diagnosed later in life, right, you may have children already. They should, of course, get tested and be screened. And if positive, they should be screened as appropriate. So don't forget the rest of the family, including siblings, parents, cousins, et cetera.
How do the screening guidelines address cystadenomas?
Yeah, so we didn't get into it in the guidelines, and we actually did separately look at the question of broad ligament tumors in the female reproductive tract and epididymal cysts in the male reproductive system. And the reason that they didn't make their way into the specific guidelines is really twofold. The first is that there's actually very little evidence in the literature about how best to screen for them. The other reason is that there isn't necessarily any evidence that identifying them early and intervening improves outcomes. So remember, we're talking about screening for asymptomatic tumors here. And there's really a question as to whether if you routinely identify an asymptomatic cystadenoma, so one that's not causing any problems, if it's best to intervene, meaning to do like a surgical excision or something like that, or whether perhaps it actually might cause more problems, right? And so, of course, if somebody has problems with infertility or pain or things like that, which can happen from these types of tumors, then an appropriate targeted evaluation and imaging would make sense. And then when they're causing symptoms, you have to have a real discussion with a subspecialist as to whether surgical intervention or any kind of intervention is the best option for that patient. But there really isn't evidence right now. And this is what the people in the consortium who are tasked with addressing this question, the female and male reproductive systems and their tumors, there really isn't evidence that if it's asymptomatic and you do find it on routine screening for whatever reason, if going in and intervening would actually improve patient outcomes. And so, since we don't think that one would do anything with this information that would help the patient, we didn't think it made sense to go and specifically image for it, to make recommendations to image for it, particularly because if you do recommend the image for it, then people may feel that they need, if you find it, you need to remove it. And if it's small and asymptomatic, that surgical procedure may cause more morbidity than just leaving it untouched.
Dr. Daniels, once again, thank you so much for taking the time to join us today, as well as everything you do for your patients and the VHL community. We really appreciate all the hard work you put into updating these guidelines, and they're going to make a huge difference in the VHL community for many years to come. So thank you so much.
Well, thank you so much for arranging this. And it really wasn't just me. You know, you can see that there were about 70 people around the world involved in this, and it was a labor of love for everybody. So thank you so much.
For everybody watching at home, you could find the updated VHL surveillance guidelines at vhl.org/surveillance-guidelines. You can find more information about Dr. Daniels and the VHL Comprehensive Clinical Care Center at Vanderbilt by going to vhl.org/Vanderbilt. We hope you'll join us for future events. Until next time, stay safe.